Good morning. I'm Deb Kagelmeyer. I'm a professor of physical therapy at Ohio State University and the chair of the Rehabilitation Therapist Working Group here with the Huntington Study Group. And we're so excited to have everybody. It's actually our second official Rehabilitation Therapist education course. We aim to do these at these Huntington Study Group meetings so that we can get more people knowledgeable about Huntington's, even though it's a rare disorder. We have a lot of patients out in communities getting therapy services, so I'm going to kind of spread the word. I thought that one, while I wait for the camera guy to come back, and I don't know where he keeps going, but that we would go around, since we have a relatively small group, and have everybody say who they are and what discipline you're in and where you're from. So we can go do that. I'll put you on the spot right away.
Okay. My name is Tanya Sharon. I'm an occupational therapist. I've worked here in the East Valley part of Phoenix since 1996. Lots of outpatient hand therapy and neuro. But about 7 years ago, I did transition to academia, so I'm teaching at HSG Still University in the OT program. And I saw this and thought, it's really very, very interesting. I've actually never, in my whole career of 30 years, worked with somebody with Huntington's disease. So huge about it, but I don't, I've never had that knowledge.
Yeah.
So, yeah.
My name is Sarah Parker. I am a physical therapist, and I work in neuro, outpatient neuro, inpatient neuro, and I'm actually just transitioned to academia a couple years ago, and so I'm assistant professor and clinical education director at HSG Still.
My name is Monica Queen. I have been a PT for 13 years and have recently transitioned to academia as well. I teach at HSG Still University, so I've been there for a year and a half. I'm actually studying for my MCS exam and was just telling Mary that I got starstruck because I've actually been taking the beverage classes all the way. So I'm kind of geeking out a little bit. And so I enjoy neuro and pediatrics. And I have only ever seen one patient with Huntington's. And when the flyer was shared, I thought, oh, this is a great way to help with my studies.
Wonderful. We just updated our courses too.
Hello everyone, my name is Ivo Maldonado, and I am piggybacking from them too. So I've been an SLP for 5 years, and I just transferred into academia at HSG Still University, and I have worked with geriatric and pediatric population, inpatient and outpatient and skilled nursing facility. And in Puerto Rico, I think I worked with one patient with Huntington's, but I haven't worked at all more, so it will be very helpful for the motor speech course that I'm teaching.
Okay. So I'm Maria Centeno Vasquez. I'm program director and professor at HSG State University. I'm an SLP for 29 years now. So I've seen a couple of Huntington's patients, but recently, the last 2 years, I've been collecting data for Huntington's Puerto Rico. And we have around like 10 patients in that. We're just ending the process because the process of the trial. And we're going into the data analysis. So I've been fortunate to have interaction with patients before in a clinic that I used to be director, and now as a researcher with the foundation.
Hello, I'm Ann Clues, and I work with Deb at Ohio State University, and we're on the faculty. And I also work at least one afternoon a week at the Huntington's Disease Clinic at OSU. So I've been doing that for many years.
Good morning, my name is Ashwini Rao Ash. I am by training an occupational therapist, but I'm a professor in the physical therapy programs, and I've been doing research and working with people with Huntington's disease since the mid-90s, and have been part of this working group for a while now. Welcome.
Hello everyone, I'm Rebecca and I'm a speech pathologist. I work at Tenderford Hospital in Detroit, and I've been a clinician researcher for 20 years now, but relatively new to the working group. It's been a year. I see a lot of movement disorders patients, especially Parkinson's, And then so it made sense to be involved in the Huntington's multidisciplinary clinic as well. And then I learned about this working group, and hence, has been involved for a year now.
Hi everyone, my name is Angelina Chavarella. I am a physical therapist on the outpatient neuro rehab team at Oregon Health and Science University in Portland, Oregon. I am one of the newer members of the rehabilitation working group for the Huntington Study Group. And I recently started to teach at the Oregon Institute of Technology for a new PT program.
Hi everyone, I'm Lisa. I'm a physical therapist as well. About just over 30 years, and I've been doing HSG for at least 25 of them. I teach at Stony University on Long Island, and we have HSG of Excellence, so I'm in the clinic there as well.
I'm Beth Gustafson, also a physical therapist. I'm a faculty member at Yale University in Northwest Pennsylvania. And my primary connection to HSG is working for several years now with a support group in the area. So I've had a few patients in the clinic, but primarily getting to know people in the support group run. And I'm a new member of this group.
And I'm Tara Isaac. I'm also a physical therapist. I'm currently working at Creighton University. I'm a professor there. Been a clinician for about 35 years, I think. 30 I stopped counting. And primarily in movement disorders, mostly Parkinson's, but I worked in the APA and whatnot with several folks here. So, welcome to Arizona.
Hi, I'm Michelle. I'm a physical therapist over in Henderson, Las Vegas area, Nevada. I work in the primary outpatient neuro clinic in Vegas, so I worked with my first Huntington's disease patient, and I realized that within my clinic we don't have a lot of people who see or treat Huntington's, so I wanted to make sure that at least I would get information and be able to relate it to my team. And that's pretty much it. I'm also like Monica, trying to take my NCS, so I was like, this is a great way to learn from the pros.
Hi, my name is Andrea, and I'm a speech language therapist about the students. These are my professors, so encouraged to be here, be part of this meeting and everything. I've never heard of the Huntington's disease, but I'm really excited to learn from it today with all of you guys.
My name is Kendra. I also am in the SLP department at AT Still. I'm from Wisconsin, so that's not really exciting. But my great aunt actually had Huntington's, and my grandpa was just diagnosed with Huntington's. I'm excited to be here.
My name is also Andrea. I'm also from Puerto Rico, and I also go to ATSU. And yeah, on how I mentioned they sent the flyer, and I was like, I've never heard of it, so I want to learn, so now I'm here. So thank you.
And your speech as well.
Yeah, sorry.
I'm just as a record keeping, I'm just going to send a note. Just put your name down, your contact, and your institution, just so that we can keep track. And then for the future, if you have any questions, you can certainly reach back out to the team.
Also, if we have your emails, which I should already, but this will double check, we are. We hope we're supposed to be recording this, so we're planning to post it for future use for people, and hopefully it'll be up, I believe, on the Huntington Study Group website, so that we're not just hitting this group, but that we can catch people moving forward as well. All right.
Use the mic, it sounds better.
So he wants me to hold this. I wonder if it's turned on.
They will pick it up no matter what, but instead with the mic, it'll be much better.
Do we know if it's turned on?
Maybe on the bottom.
Usually that's what we're I think everything's set.
Here we go. No, it wasn't on.
You got it?
Now I got it on. Okay. Now I feel like a rock star. All right. As I said, I'm Deb Kegelmeyer, and I am certainly not the person who put together this whole talk. I'm the giver of the talk, but this has been put together by a large group of individuals from our rehabilitation therapist working group, and that's a list of the people that were primarily involved in putting the talk together. So many individuals that have been involved in this, and we may even be missing names on that slide that need to be added and whatnot. Just a few disclosures from some of the members. Many of us are funded by the pharmaceutical companies and Huntington's Study Group and other individuals related to Huntington's disease. So a little bit of a background, so we all start on the same page since this is a rare disorder. Huntington's is a hereditary dominant genetic disorder. It primarily, but not only, affects the basal ganglia and other areas of the brain as well. It's caused by a mutation in the Huntington gene, which has DNA nucleotide triplets of cytosine, adenine, and guanine, and that's repeated many more times than it should be in the normal gene. Usually, the average age of onset is in midlife, but you can have juvenile onset, and you can also have onset after the age of 60. So it's kind of widespread, dependent on the number of repeats and some other factors as well. And then it tends to affect females slightly more than men, and it's more common in white people of Western European descent than those of Asian and African ancestry. But there are several different kind of variations. There's definitely a unique variation that's in Africa, and so we see some other ones, and we certainly see it across the globe. But it can be concentrated in some areas. These are kind of graphs just to show the typical how it onsets and how it progresses. So since we know it's a genetic disorder and we can test for it, we have this pre-manifest stage before people are symptomatic, when they're functioning fine. And so we'll call that pre-symptomatic, and then prodromal, just as things are starting to come on, but not really measurable. So we see some early cognitive and behavioral changes, again, not out of the realm of normal, but that the family and the patient themselves may notice that they've changed, and some mild motor changes as well. We're getting better at coming up with techniques for detecting those earlier as well. And then we have, once individuals go into becoming symptomatic, we classify it as early, middle, and late stage disease. And you can just see the progression through areas of the brain, as well as symptomatically what we might be seeing with individuals. So pre-manifest, we have that, as I mentioned, that pre-symptomatic stage with a period before onset of cognitive, motor, or behavioral symptoms, and then prodromal, the period just prior to diagnosis, where we may have some changes that are going on, but again, not outside of that realm of normal, or not to a point where they meet the criteria for diagnosis yet. This is a disease that affects many aspects. And so it definitely takes a multidisciplinary approach to provide patients with the best care and to support the family as well. So members that you may see on multidisciplinary teams, any combination, the neurologist, neuropsychologist, dietitian, caregivers, speech language pathology, physical and occupational therapy, psychologists, and social workers. And boy, are the social workers important. I'm just going to put a plug in for them because they are super helpful. There's the Huntington's Disease Society of America, which is the group that primarily focuses on patients and caregivers. And so that organization has a lot of resources as well, and they support the Huntington's Disease Centers of Excellence. So all over the country, in every state but the ones that are in gray, there are centers of excellence, and we see that New Hampshire just got added, so I colored it in green up there. But those centers of excellence have to have a multidisciplinary team approach. They have a lot of training and experts and typically are running most of the clinical trials in Huntington's disease. So we think about when should people be referred for services to rehab therapies, and the message we're trying to get out is that that should happen early on. And people should stay in contact with those therapists. We should be managing that care throughout the course of the disease, whether they're in that pre-manifest or the middle or late stages, regardless. So at diagnosis as soon as they know. And it's not, some people we don't see until middle to late stage, and other people we've known them all their lives because they're part of a family with Huntington's disease, but definitely wanting to get them into rehabilitation therapies early. Anyone can refer. And do you need a prescription? Well, that's going to depend. For physical therapy, in most states, you don't have to have a prescription, unless it's Medicare, at which point after the evaluation you do. But pretty much always required for speech language pathology and occupational therapy. We put out a guide, which we had a poster here. There are some guidelines for physicians on referral to each of the disciplines, suggesting maybe some language and areas and things that they may want to refer patients for. So that can be another resource to help. We'll go through this ICF model as we go through each of the stages, so I won't spend much time here right now, but of course thinking about what are the activity and participation limitations, and then what are those personal and environmental factors that may be impacting individuals. There are many symptoms that someone with Huntington's disease may have. They undergo changes in their gait, typically developing a wide-based gait, and it will progress to become quite ataxic. And path deviation is very common in Huntington's disease, so the weaving may be mistaken for drunkenness by people in the public or police officers. They have impaired balance and postural reactions, also impaired coordination, including eye movements, an area that doesn't get a lot of attention, but facial muscles as well, orofacial musculature, they develop dysphagia. Chorea is kind of jerky, uncontrollable movements, and so again, they may be jerking around and moving uncontrollably and then weaving. So it's socially notable and it can be embarrassing, and also again, sometimes raises people's suspicion that there's something different going on there. They can develop dystonia, typically. Posturing, I know a common posture that we see in our clinic is kind of having the arm turned around, facing backwards, so get dystonic posturing at the neck can lead to contractures and difficulty there. Increased tone in the form of rigidity, and they are bradykinetic, which sometimes is kind of hidden by that chorea because you see a lot of extraneous movement, but purposeful movements are bradykinetic. There's impairment of cognition, so developing over time and worsening over time. They have particular difficulty with sequencing activities, so we'll talk about working on sequencing and how that impacts daily function, as well as trouble with attention and concentration, declines in executive function, visual spatial processing, can be impulsive and lack insight, and so safety awareness is an issue. Also, apathy is a big problem. And it's one of the more frustrating problems because we don't really have a good way of treating or managing apathy, but it significantly impacts participation in daily life. Depression, anxiety, irritability. Irritability can be one of the first symptoms that patients and families will report. Anger, aggressive behavior may come along, perseverative and obsessive behaviors, psychoses, personality changes, you can have sensory dysregulation and fidgeting, and then social isolation, something we're trying to avoid. So all of these occur over time, may not be, many of them are not present early on, and then as the disease progresses, we start to see them come along. You think personal factors can impact, and we're finding out they can impact time of onset. So we used to think it was more tied to how many repeats they had in that CAG gene, but also lifestyle impacts that. Keep trying to find out what are the other factors that go along with that. Baseline activity level is definitely going to impact individuals. What other health conditions do they have? What's their motivation? And family support is extremely important. We'll talk more about this, and we have some case examples, but also recognizing that if you work in the Huntington's community, what you quickly realize is you're involved with the families. And it's dominant, so it's moving through the family. Not surprising to hear about people having multiple family members. And so we often have individuals and families that are taking care of many family members who have Huntington's disease. But that family support is very critical. What's the living environment? How accessible is that living environment? And their neighborhood and other safety factors there. And then what's their access to healthcare and to healthcare practitioners that understand and have been trained in Huntington's disease. There've been a couple studies, smaller studies, looking at what are barriers and facilitators to participation in therapies. Now, the top one was particularly looking at physical therapy, but I think they apply broadly. And there was a survey that we did of physical therapists really around the world. And what they identified as facilitators to being able to provide best care in Huntington's disease were having expertise in Huntington's disease, so getting that training, having an individualized plan of care, and having support from their colleagues. We know that a lot of our neurodegenerative patients take a little more time and require that extra time that's not always given to us in the clinic. And then barriers that therapists identified, they were all patient-related, were apathy, lack of motivation, and the cognitive deficits. So all tough things, but things that can definitely impact how a person's able to participate in our therapy programs. In another study, they broke it down more by personal and external factors, and there's where it came out pretty strongly that if people were able to participate in home exercise programs, therapeutic recommendations that therapists were making, the one key factor that was typically present was an active and involved caregiver. So having support people is very important. And again, the barriers, cognitive impairment and lack of motivation popped up again in that study as well. So talking about prodromal Huntington's disease, we have a case study that we're going to walk through today, and it's Mark. And at this stage, he's 44 years old. He's a right-handed male with a positive maternal family history of Huntington's disease. And he was diagnosed on his visit through genetic testing with Huntington's disease. He enjoys running in his community. He's running up to he's doing 5 miles a week. He also enjoys boot camp at his local gym, so we're going to keep that in mind. He's divorced. He lives alone in a one-level condo in a building with an elevator. And he has 2 children. They're 19 and 15. He works full-time as an administrator in a municipal office. And his mother also has Huntington's disease, and she's in the middle stages. So we don't expect to see motor impairments at this point in time, nothing that's really impacting function, as he's prodromal. We may see cognitive, hear the family or friends say that there's been some cognitive changes or behavioral, but again, won't show up on testing in this stage and shouldn't be changing like his ability to work and those things. And some of the things that may happen that people will note that are changing with these individuals, maybe less motivation, showing that maybe the start of some of that apathy, anxiety and depression, maybe having more of that, and then some sleep disturbance. So really key right now for all of the rehab professionals would be developing that working relationship with Mark and with his family, and for them to know who we are, the kinds of services we can offer so that they know when they can be asking to access those services and be advocating and initiating for them as well, helping them find a support network, making sure Mark and his family have that. We also want to establish baseline measurements. So regardless of the fact that we think he's going to score, we know he's going to score very well, getting those measurements, having them on the record, so as we follow him over time, we have a very nice idea and record of what's been going on. And we want to start to prescribe individualized activities and exercises to help Mark get optimally functional, and then to make sure he's maintaining that. And so slowing down progression. So education and discussion are a big part at this point, is making sure that they understand and know about Huntington's disease. I know we've had families come in and they're like, I don't understand. There's 4 people in our family. I've had people that worked in skilled nursing facilities, nurses say to me, I don't understand. This family has the worst luck. No, it's like, no, this is a genetic disorder. So again, rare disorder people aren't aware, so making sure that they understand and know what the disease process is. And there are so many resources for Huntington's disease, really active support groups and organizations. Talking about the importance of regular physical activity and how important we believe that is in helping preserve neural health and help with neuroplasticity. What our roles are, who the people on the team are, who they could ask to bring into their team if they're not part of that multidisciplinary team. And then talk about the clinical trials and how they may benefit to be a participant in clinical trials. We've made a lot of progress in Huntington's disease. Thank you to the patients and families that participated in those. And then again, exploring all those resources, support groups, Social Security disability services, thinking about the Bureau of Vocational Rehab, things like that that are out there. The number of baseline assessments that we've recommended. I know on the physical therapy side, there have been some studies to start to look at which ones work best, and we have more work to do on that front, and then other ones from the occupational and speech therapy side. So trying to pick out and choose key ones here, and again, doing them now and following all along. So the UHDRS is the Unified Huntington's Disease Rating Scale. It is the measure for looking at disease severity. And if someone's being seen in a Huntington's Disease Center of Excellence, that's the scale that the neurologist will be doing. So there's a motor scale part of that. That's the type of testing they'll be doing, and then they'll be tracking the disease along the course. Anyone can do the motor scale of the UHDRS. It does require online video training, and there's a small fee attached to that, but you can be certified if you want to be able to do that test. And then we've recommended the Burke Balance Scale, the timed up and go, along with timed up and go cognitive and manual, activity-specific balance confidence scale, looking at fitness, whether it's predicted or actual VO2 max, and then some type of measures or screens for cognition. In our area, we've looked at the MoCA Montreal Cognitive Assessment as well as the St. Louis Assessment. The UHDRS, the Huntington's Study Group team, does have a battery of cognitive tests that again are typically done in the centers of excellence. That includes the Stroop, the Simple Digit Modality Test, and the Verbal Fluency Test. So those may be, should be being done, and those are the ones that are most commonly followed in all the clinical trials. And then under activity, the 6-minute walk test, the 10-meter walk test, functional gait assessment, 5 times sit to stand, UHDRS again, and then a routine task inventory, the modified Barthel, occupational therapy, driver off-road assessment battery. That may be done earlier just when concerns start to arise with driving. The SF-36, the World Health Organization Quality of Life are two of the more commonly utilized participation measures, but you might also consider the Latin Instrumental ADL scale, looking at the Social Security disability measures, the HGQ quality of life subscale for speech and swallowing. And there's that full HG quality of life measure as well. And then the communication participation item bank short form and the life space assessment. So lots of measures to choose from and look at across the team. Again, trying to get that baseline. And then I won't repeat them every time, but we'll be looking at reusing these measures each time Mark comes in for follow-up. So early in this phase, what do we want to do? We want to encourage physical activity. For someone like Mark that's already running and going to boot camp, we're going to encourage him to keep doing that. For someone who's more sedentary, we're going to try to see if we can get them interested in getting more involved in some type of physical activity. There have been several studies looking at physical activity in Huntington's disease that have had success in getting people safely participating in physical activity. Those studies did provide a lot of external support. I believe all three of them were primarily done in Europe. They provided transportation. Often they provided, again, follow-up calls, people, so a lot of like supporting the person, encouraging the person, following back up. And I think that's important to remember with individuals who have issues with motivation and apathy, like we see in Huntington's. They did demonstrate, though, that it was safe and feasible and that you can overcome some of those barriers doing things like this. And they were, one of the other things they did nicely in most of these was setting individualized goals. I know in a lot of studies we just have our standardized measures, but they worked on individualized goals and following those as well so that it was meaningful to the individual. Some of the results from them, again, focusing on what we would typically think of our 4 pillars. So aerobic exercise, pretty much the standard recommendations there. Resistance training, again, looking at being progressive with that and performing that about every other day. Flexibility, add-on, and not to forget that neuromotor balance component. People need to optimize their balance and then really work on maintaining balance because it becomes such an issue as the disease progresses. So now I'll go through each of the disciplines and talk about some discipline-specific things we'll do in these phases. So for occupational therapy, again, the focus is on prevention at this point and looking for activity engagement, trying to preserve function, and thinking about cognition as well. So building that cognitive reserve, doing things like structured practice of challenging tasks, working on multitasking, working on paying attention, concentrating, and sequencing. So at this point, building up those skills. Also starting to teach cognitive compensatory and energy conservation techniques so that the person has those in their arsenal. Working with the treatment team, social work, we have psychologists who help people continue social participation. People sometimes start to socially withdraw very early on. We want to try to keep them from doing that, practicing mood and sensory regulation as well. And then working with patients and caregivers on hand coordination skills. And again, through your typical standardized assessments and functional activities. Something that's a little unique to Huntington's disease is they develop something called motor persistence. And so if someone with Huntington's disease was standing up here and holding this clicker, started to think about talking with you, I would drop the clicker. It would happen over and over again. It's very common in Huntington's disease. It's functionally limiting. It's been an issue with things like dropping cigarettes, dropping dishes, drinks. So seeing if people are having issues with that and developing strategies to deal with that. That may become more of a problem in later stages, but again, we're trying to optimize that at this point. And then maintaining independence in instrumental ADLs and looking at driving and how that's going to impact the individual. For speech language pathology, a big part's getting started and establishing that rapport. Having a rapport early on really smooths the way when you go to work with someone once they develop problems and issues. Working on that cognitive reserve again and doing brain health activities. Reinforcing physical therapy recommendations for exercise and activity, because we know that helps with cognition as well. Reinforcing oral care and the need to continue oral care and dental care. That becomes one of those things that's like just one more thing, and then people stop. They're not able to do it themselves, and maybe it's hard to get them to the dentist, and so we see a drop off on that and want to make sure people realize it's very important. Screening and education counseling for communication, speech, voice, language, and swallowing problems based on that individual and their needs. And then collaborating with the rest of the team to set up goals for that individual. We don't expect problems again in this stage. We're looking at setting them up and optimizing function for continued success. So we have our clinical pearls: stay active, maintaining current occupations. We've seen a few people who've said, oh, I tested positive, you know, maybe I should quit work. I don't know if they're having a bad day at work. Good, I have an excuse. But we want to discourage that kind of thinking. On people to stay involved and maintain their things. Exploring resources for that. And then again, building up that cognitive reserve and oral and dental care. Early stage, what's happening with Mark? Now he's 49. He still enjoys running in the community a few days a week, but his mileage has dropped down. Also, he enjoys boot camp classes, but maybe he's not participating as much in those. He continues to be divorced. He's living alone in that condo still. His children are a bit older. They're 19 and 24 at this point. He's continuing to work full-time as an administrator in that municipal office. And his mother is now in the middle to late stages of Huntington's disease and is requiring more assistance. So Mark is a caregiver for his mother. So now he may be having more problems with body structure and function. They would be mild at this stage, but again, may progress over time. Starting to experience some changes in the ability to perform ADLs and IADLs, and likely is still independent, as we saw in all his activities. And he may be seeing changes in life roles. So we know one important one for Mark has been he's having more of a caregiving role with his mother. So what's that impact for his ability to care for himself? When as 19 and 24-year-olds, he's still, you know, very much a parent and caregiver for the children as well. Motor symptoms that now may be more present: fatigability, starting to see widening of the base of support during gaits of some of these. I know we notice very early on that people can hardly stand on one leg. Just as a sign of the types of balance and postural things that are coming on. Some of the other tests we're not picking up on changes, but that one seems to show up early. Impaired coordination, maybe starting to develop some chorea and oculomotor deficits. He may have some impairment of memory and recall, difficulty sequencing, and then deficits in memory, executive function, and visual spatial deficits.
So the oculomotor deficits, what do they look like?
I'm gonna let Lisa talk about this oculomotor deficits.
Yeah, that's fine. So early on, you're looking to see if they can do even voluntary saccades all the way across the range, both vertically and horizontally. And often you're seeing vertical are impaired before horizontal are impaired. And so looking to see how they can scan, if they can keep their head straight, put different things around, and see where they can scan all around.
Sometimes in addition to that, there is a delay in the onset of the saccadic eye movement. And then even with smooth pursuit movements, you can see jerkiness of the eye movements. And again, particularly with the vertical first and then the horizontal.
Just like a little bit later than the horizontal.
let's see, apathy, depression, those may be starting to make more of an appearance, irritability, anger, and changes in social skills and changes in communication. We often hear family talking about kind of changes in the individual. As I said, the assessments are all of those that we talked about earlier. Hopefully we've done those, we've gotten a baseline, and so now we're repeating them with Mark to see where we are and just exactly what has changed for him. So what does Mark say his concerns are at this point? He wants to continue to be able to take care of his children and do his job. He's concerned as he feels he's not as quick cognitively as he used to be, and he fatigues more easily with difficult tasks. He knows that he's clumsier than he used to be, but he's not having any notable difficulties with daily tasks. He knows it takes longer to finish meals, but he doesn't think he's choking. Occasional word finding and difficulty in losing his train of thought during conversations. And he's seen his mother's symptoms progress, and he wants to stay as functional as possible. His sister is expressing that Mark seems more tired and irritable, and she's expressing concerns about his ability, what's going to happen as this progresses with his ability to stay employed. So treatment strategies here, we're going to continue those preventative strategies and restorative where we're starting to see problems or where he may not be optimally functioning. So we're trying to maintain those current life roles. We provide caregiver education, so talking to that sister and possibly the children about how to help motivate Mark to stay involved in those exercise programs and other activities. Thinking about insurance benefits and financial affairs. Now, Mark's already had genetic testing, but optimally, people consider that before they get the genetic testing and see if there's anything they need to set in place before they have that positive genetic test. So there's a lot to think about and weigh that families need to be doing. And then referral to a social worker or case manager. We really like to, hopefully they're on the team, but if you don't have that person on the team, then trying to get them involved with someone in that role. Screening for suicidality. Suicide, unfortunately, is more common in individuals with Huntington's disease. Some of that ties into impulsivity and certainly the depression. So screening for that and making sure that mood and behavioral disturbances are being optimally managed. And then considering at this point in time, being sure we know what Mark wants to do and what his advanced care directives are. We're going to push aerobic exercise, encouraging him to, we know he likes to run, so definitely encouraging him to continue that running program, but even starting at this point to talk to him and think about what's the strategy when balance becomes impaired and coordination and he's not able to run. Maybe thinking about a stationary bike. If he's having trouble running in the streets where terrain is rougher and maybe more hills, so we want to switch to a treadmill. So strategies to maintain that exercise program that he's had, but maybe do modifications to make that possible, because we don't want him cutting down on the amount, we want him to keep that up. Then strengthening exercises. He's been doing boot camp, which is great, so we know he's into that kind of exercise. So is he still able to do it the same? Is he having any problems, again, with withdrawing because he doesn't feel as coordinated or maybe other issues? So keeping him actively involved in that. And if he is having any problems, how can we modify again to give him instructions where instead of just, most people, if something becomes difficult or they don't feel safe doing it anymore, they just stop. So we don't want him to stop that weightlifting or whatever element of that program is difficult. We want to figure out how we can modify that. Looking at oculomotor muscle strengthening and vestibular rehab exercises is appropriate, and also oropharyngeal strengthening. Making sure we're optimizing all the muscle groups. Making sure Mark's doing some balance things. So running outdoors is probably challenging balance, but I am always asking individuals, it's great, weightlifting is their big thing, but what are we going to add in that's balanced?
because that's an important thing to maintain. And then doing pediatric things for coordination and dexterity as well. We train in our clinic very early on stairs because we see a lot of falls on stairs. So we start getting people now while they're cognitively able to start the habit of we have them stop, think, and use the rating. And that's kind of a mantra we teach them is stairs because they tend to the family will describe that they almost like, especially when you're down and run over the edge and run down, kind of out of control. So stop before you go and then think about it and climb the stairs now and hold the rating. And we've found good success in teaching that holding the rating early on and then they continue it. There's many people who are falling down stairs we found work using the rating. And the later in the disease it gets, the harder it is to establish that. And then flexibility exercises, particularly dystonic muscle groups, but anywhere needed to help people maintain a good posture. Dual task training is going to help with functional activities as well as cognition, and then cognitive training. So we're going to be teaching things like teaching them to try to concentrate on one thing at a time. We all have that habit at work. I know that I'm often talking to someone and looking at my email, but that he's going to have trouble with that. You need to be more focused on one thing at a time. Setting up routines, breaking down tasks into smaller sections, writing down tasks in sequential order can help with that difficulty with sequencing, taking breaks to reduce fatigue. We did a treadmill study, and the one thing our Huntington's patients, when they would ask to take a respirator, they wouldn't be breathing real hard. And we'd say, what's up, and I'm tired, my brain is tired. And they were very much having to work cognitively to not fall down on the treadmill to do that. And they were getting cognitive fatigue ahead of physical fatigue. So recognizing you need to rest and that can happen. Checking for sleep apnea, insomnia, poor sleep hygiene. Poor sleep hygiene, it's really common. So I was starting to up days and nights, do too many naps, those kinds of things. And reducing stimulant caffeine consumption. There's a lot of caffeine consumption in this population. So asking about that, watching for it. And then strategies to overcome emotional and behavioral impairments, irritability, we want to avoid confrontations, speaking in a low, soft voice, keeping the environment calm and controlled, and playing calm, soothing music may help, and limiting choice options. For depression and emotional support, what kind of support would he prefer? Anxiety, teaching breathing exercises, and exploring are there certain things that are bringing out that anxiety, that are more anxiety provoking for that individual. And then apathy. We don't have good answers for that, but establishing routines, people will tend to continue things that are really routine for them. Setting goals with rewards and choosing activities that have been interesting and are still interesting to that individual. And then task-specific training transfers from the floor. Training sit to stand, that becomes a problem later on. It's one of the areas where people tend to fall. Walking, especially walking, hearing things, walking and talking, those kinds of issues. And then activities of daily living, checking in on the driving. That's a difficult conversation. It's a conversation that is best had kind of starting early on, going all along. I know where we are, there's not really public transportation. If we don't have public transportation, then this is a big deal to lose the ability to drive. So starting to make plans and think about that as a family. Exploring job-related tasks so that they can remain employed and possibly just modifying as things go on, and then financial related tasks, which ones is not doing, and again, how are those going, making sure that the family and mark on supplies to find out that I thought he was doing all right, but in actuality, he wasn't getting all the bills paid or the problems coming along. For speech therapy, and encouraging early referral. then to start looking at speech and swallowing problems start in an early stage. So being aware of that and then getting oral care. Some compensatory strategies, speaking low, speaking loud, improving breast support. So we've seen breathing kind of across the disciplines, providing compensatory word finding strategies, stopping and thinking to organize thoughts so that they can find their words. And then choosing easy to swallow foods. Speech that we're talking about what those may be, limiting meal time to 20 to 30 minutes, monitoring weight. Historically, individuals with Huntington's disease have had problems with losing weight and low weight. We're not seeing that as much as we used to. Now we even see issues with weight gain. So monitoring for that and then thinking about aspiration precautions, certainly teaching the family what to watch for. And then maximizing, again, as part of that participation in life goals. How can they continue to do that? And what's the best way to do that? Discussing their concerns about work. Considering involving social work for thinking about that and how that's going to progress. What about childcare, these children, hobbies, recreation activities, and social activities? And does he need help in his caregiver role for his mother and then also for children? So clinical pros there, again, staying active, increasing activity, addressing any impairments as they come along, maintaining current occupations and restoring resources if they're having trouble doing that, and then building cognitive reserve and looking at oral and dental care and reinforcing awareness of dysphagia issues. So we need to talk to the family about exercise. And diseases like Parkinson's disease is kind of all over because everyone's hearing about how important exercise is and how it helps keep the brain healthy. That message isn't out in a lot of the other neurodegenerative disorders. So making sure that the patient and family understand that exercise is very helpful to brain health, not just to overall body health. That seems to motivate people, knowing that this is going to actually help the brain. Encouraging coaching from the family to help a person stay active and involved, and setting collaborative goals and then rewards and praise when the person does those. Providing resources about support groups, and then making sure that everybody feels safe, and then checking in on suicidal ideation. Middle stage, this is where we really start to see all those symptoms that we talked about in early stage. So now Mark is 52. He tries to get out walking a couple of times a week, but he's nearly fallen several times. He's experiencing decreased enjoyment and feeling apathetic. Towards running and other activities that he used to do, so this is not uncommon. So it's being cut back on those. His daughter has now tested positive for Huntington's disease, and in response to that, quit college and has moved back home. Decisions regarding his work need to be made because he's lost his job as an administrator and is having increasing difficulties to step down to a role as an office manager. Ideally, in employment situations, we do see people kind of changing their role. And it's really wonderful when we see workplaces that accommodate that and keep providing new roles for individuals based on where they are in the disease. But many times we have to help people find new job opportunities, and again, encouraging people to seek out those types of opportunities rather than just quitting. Life goals is helping care for his mother, who's now in the late stages of the disease. He's had 2 car accidents involving poor turning radius, which is pretty common. We've heard about that plenty of times in our clinic, and impaired decision-making driving, particularly in unfamiliar environments. And he needs to drive because he's the sole income earner in his household at this point. So we're going to do an activity assessment. He's having now difficulties in ADLs and IADLs and work. We're going to look at bed mobility and transfers. They're becoming more difficult. The imbalance have changed. and he has notable issues there. He has difficulty walking on uneven surfaces, stairs and curbs. And I think we forget about curbs, but as I'm always telling patients and students, curbs are just stairs without a handrail. So lots of falls there, and they require a lot of single leg stance time, which we saw already impaired in the early stage. And then decreased independence with toileting, moving, and hygiene, and needing some assistance or supervision with those tasks. He's beginning to slur his words, choking on liquids occasionally, and has trouble swallowing pills, particularly the ones, and he's lost 10% of his weight since his visit a year ago. Reasons people lose weight, we're not exactly sure. It may be chorea, difficulty swallowing, motivation to eat. If there's not some linear time, individual meal time, they may not do it. On the other hand, we're starting to see people with weight gain, which may be decreased activity, unhealthy choices in food, and sedentary lifestyle. And then there's also decreased activity tolerance due to reduced cardiovascular capacity and more chorea. So chorea is much more notable now and probably problematic. Mark may not be reporting the problems with chorea so much as his family. That's what we typically see as family members talking about more than the patient himself. But asking, is he having trouble doing things because of the chorea? So he may be able to know what the functional limitation is, rather than really having a good sense for how severe the chorea is.
Question time, is the cardiovascular capacity decreased because of the chorea, or is that actually physical?
It's a little hard to wean out where the cardiovascular decreases come from. We see such a decline in activity, but that's certainly a large contributing factor. I don't know if anybody asked you want to.
Sure. I think part of it is due to limitation in activity, physical activity overall. But part of it is that there's also a mitochondrial deficit in the muscles, and that also limits cardiovascular capacity.
Okay. But most of the neurodegenerative disorders have mitochondrial defects, which that's the energy storehouse. So it's going to make it difficult on muscles. The other thing that patients with Huntington's disease and getting neurosurgery learn is they have autonomic neuropathy and autonomic problems. So watching for how well are they able to regulate. Pulse rate typically doesn't go up like you would expect during exercise, or it'll go way up and come back down. I know in the studies that have been done, it's been very hard to kind of hit a pulse rate like you typically do with exercise. So usually you're watching people go up, down, and down. So there's a lot of changes like that going on as well. Now, this is kind of that whole list of symptoms that we started with, what might happen with Huntington's disease. So we're in middle stage, and we're seeing them all now. So lots of those problems with physical things getting balance with the cognitive, and then again with the behavioral and motivation and apathy is certainly, I know I say it a lot, but it's a problem. It's really hard to get someone to do something if they're apathetic. You can't help it if they're apathetic. This is part of the disease process. And irritability, anger outbursts, those kinds of things are very problematic for them socially and with family members. So getting good psychological management strategies so that they can deal with those issues. Just to reinforce, we're continuing to do those assessments. So we've had our baseline, and now's the time when now we're doing those assessments. We started at baseline, and now we have a very good idea of where has Mark seen the biggest changes, and how has he changed, and kind of what's that rate. And so it helps us get a better story on Mark and know where we may be able to improve things and where we need to put the compensatory strategies. So PT, we're still pushing for exercise capacity and remaining active. We probably have to modify that and look at ways to do that to make sure that people can remain active and trying to decrease the impact of fatigue. And then working on things like sit-to-stand transfers. One of the things that we've noted is that if when I have people that have a lot of create, particularly in the trunk, is that I have them put their hands on their thighs when they go to sit down, and then slide them down the thighs as they sit, and then I have them do the same thing standing up. It seems to kind of give them better trunk stability. They don't crash land as much, and you always have your legs with you. You don't always have something else to push off on, but I've found that to be one strategy that seems to work really nicely for individuals with Huntington's disease. Looking at transferring in and out of bed safely and efficiently. Walking, again, can do sidestepping, turning. Those are areas where we tend to see falls occur. And then talking to people about minimizing dual tasking. Because of the cognitive changes and impact on the areas of the brain, like the basic ganglia, that ability to dual task is very impaired by middle stage. And in all likelihood, they need to compensate by, I tell people start going for walks. I want you to go for walks with your family members, but try not to hold the conversation while you're walking. When you stop to admire something or to take a rest, have the conversation and then go on with the walk without cognitively loading. We start looking at, I'm a big proponent of the rollator walkers that have a basket or a seat platform, and one of the bonuses, if nothing else, is that they can put things on that, in that basket, so they're not dual tasking and carrying things, which can definitely lead to more falls and problems like that. Working on task-specific balance training, static and dynamic balance, permanent uneven surfaces, all of those. Again, we know a lot of our clients and patients, they're not optimal in their function. So how can we work to get Mark back up to his best self and then to maintain that and try to slow down the changes. Looking at visual inputs, addressing single limb stance, practicing reactive stepping. And addressing single limb stance may be coming up with strategies for those situations. Again, when someone has to do it, but they're just not really able to do it safely. And then coordinating with the neurologist if it is really becoming an issue. There are medications that they can use for that. Range of motion and posture, again, especially in your dystonic muscular areas, and really looking at can you maintain upright posture, because it impacts everything. But we know for sure it in fact impacts swallowing and breathing and a lot of really important functions like that. Occupational therapy is looking at maintaining those activities of daily living, looking at adaptive equipment. Again, with that thought to getting adaptive equipment, if anything, a little bit early on, so that the person is able to get in the habit of using it and understand how to use it before they lose the cognitive reserve for figuring out how to use that adaptive equipment. Self-feeding, what type of seating, are they sitting in a good seat for eating, are they maintaining a good upright posture, those kinds of things. Is any adaptive feeding equipment needed at this point? And having a quiet environment on where they can focus on. Working to do home safety assessments, things like removing throw rugs, small furniture, electrical cords, and a lot of times, because this is a disease that affects people, it tends to be at a younger stage. There may be young children in the home. They tend to create a lot of obstacles on the floor. Working on memory training, problem solving, work restructuring, and then the driving assessment. Fatigue, teaching energy conservation strategies, if they can deal with fatigue, and then restorative and adaptive hand coordination activities. They may need durable medical equipment in the shower, shower modifications, maybe alternatives to showers, you know, especially when there's bathtubs in the home, you have to step over, you may really need to look at modifications. Dressing, you know, you may change up the style of clothing to make it a little simpler. So not so many snaps and buttons and things like that. So promoting independence for that individual. Sensory-friendly clothing. I know not that it has anything to do with Huntington's, but my younger sister was such a pain because she used to complain about scratchy clothing, quirky clothing, and that there are people, and Huntington's got are more sensory, sensitive to that, and talk about irritability if your clothing is bugging you. And I get irritable if my clothing is scratchy. So is it sensory-friendly clothing? And providing choices. And then toileting, doing adaptive toileting equipment and continence supplies, and your toileting schedule. Same thing with feeding. Do you need any adaptive equipment? Sometimes it's just changing it up. It doesn't necessarily have to be special equipment, so you need special equipment, or maybe just the type of bowls, or, you know, people, I'm not an OT, but the breakable plates, you know, it's amazing how many times I say, how about getting some plastic plates? Oh, you know, so let's not have any more broken dishes. Let's just switch to plastic. Making sure the food that's presented is appetizing, and that becomes more important, more of a challenge as we're starting to have to modify foods for food consistency and issues like that, and using straws to be something. And then remembering that eating is a social thing. And people eat more when it's social, and it's rewarding, it smells good, so trying to keep all of those things in place. Speech therapy during the middle stages, looking at dysprasia. It may be time now for swallowing evaluation, so maybe the bedside swallow evaluation, video fluoroscopic swallow studies, modified barium, or fiber optic endoscopic evaluation of swallowing, and then looking also at dysarthria. Speech becomes harder to understand. So there's several assessments recommended there: the French dysarthria, the Newcastle dysarthria assessment tool, grandfather passage, and the GRBAS, the grade of hoarseness, roughness, breathiness, asthenia, and strain. And then checking for cognitive linguistic deficits or cognitive communication impairment. So the repeatable battery for assessment of neuropsychological status. The Montreal Cognitive Assessment and Meaning Mental, and then social communication skills as well. And again, there are those cognitive tests that typically are done with UHDRS. So depending on if you're at a center or not, you may be getting those. Dysarthria, teaching things like over-articulation, slowing rate, intonation to try to improve intelligibility, train lightweight speech aids, and then adapt as they progress. And again, I think thinking about these things earlier on, because it can be difficult to adapt to those aids in later stages. So early exposure, no harm in that. And then for cognitive communication deficits, educating the family and caregivers. And you never know who caregivers are. We have a couple patients who their supervisor brings them to clinic. It's the person who's providing the most support and care in their community. So whoever that person is, but getting them in there, providing education, talking about cognitive communication changes and strategies they can use, and how all this is impacting potential home safety, teaching strategies to improve language comprehension, effective daily strategies and aids for memory, like alarms and lists, and developing maintenance activities for quality of life, meal prep, cleaning around the house, and routine daily chores. And then improving communication, improving participation in household management. And for dysphagia, keeping thinking about that quality of eating and drinking. If necessary, refer to a dietitian. We have people, like we had one gentleman who would send someone out and they got, I think it was Wendy's, something like that, like 3 Wendy's meals, and then that's all you eat all day, every day, the same 3 Wendy's meals, which great, but there's not a lot of variety of nutrition in there, so the dietitian would be a good person involved then. Respiratory breathing exercises, inspiratory muscle training to improve cough efficacy and respiratory muscle strength. And then based on study results, may need to modify textures, may need to do thickened liquids, using straws and straw strategies, checking sitting posture. So many people that sit in the recliner, right, recline back and trying to be in that position as well. Modifying those things and recommending some maneuver with intake as well. Again, we need adaptive equipment, different types of adaptive straws, and then making sure that everyone in the family and the household knows the Heimlich maneuver and what to do when an individual is choking. Also talking about dysphagia and what the risks are, making sure they understand that it's not just choking and dying, but that aspiration may be occurring and the importance of understanding that. And again, watching oral hygiene, that that's not dropping off the radar, and that someone's making sure that's happening. Some complexities that are fairly common. You know, Mark is taking care of his mother who has late-stage HD, and then he has a daughter who's dealing with a new positive genetic test. This is not unusual. So we're often working with families who have someone in the family is having to do caregiving across multiple individuals. And so a lot of support needed for those caregivers and families. Many times caregivers also have Huntington's disease. So how can we help with that? Job difficulties, again, modifying versus stopping working. Unless that's absolutely necessary. I know recently we had a couple people who had to stop and they said it was all anxiety. They got so anxious about small errors they were making that it became incapacitating. But how can we manage that and maybe try to avoid that? Driving difficulties, again, that conversation when to retire from driving. It's a tough one. I think it's easier though if people are thinking about it. It's not a shock all of a sudden. And then that apathy can put a lot of strain on relationships. So working with that and watching for weight changes. We have no weight loss, and we can really which direction is that going. We've talked about the multidisciplinary approach. It's fantastic. I think it's one of the great aspects of Huntington's is that we work in a multidisciplinary clinic and really experience that. But then we just talked about a lot of recommendations from every single team member. So key to that approach is making sure that we're coordinating that care, providing comprehensive and cohesive support, so that we're all kind of speaking the same language, and that we're reinforcing what each other is saying. I know we work hard on that in our clinic to make sure everybody's kind of giving the same message as they're going in. And sometimes the first person gets the brunt of the, I don't like the message you're giving me, and then by the time the last person's in the room, they acceptance and somebody that's ready to be more compliant. But we need to make sure that we understand that there's a lot going on. And so it may be that as the therapist and I'm going in there talking about balance or exercise or these kinds of things, that maybe the Mark's had all these work changes and he's having swallowing and eating challenges, and it may be that it's just too much and that the focus right now needs to be on those work changes and swallowing things, and you kind of have to set aside what we're doing with physical therapy. So choosing areas to focus on as a team and with Mark and his family, and being mindful of everything we're asking of them. And then that influence of the personal and social environment and how what's going on with that. And again, that caregiver support. The habit, how's the caregiver doing? So some clinical pearls, it is still possible to improve function. Always, because where's the individual who's just like totally optimally functioning, right? So if they're having a problem, there's a good chance we can improve that function somewhat. But we are relying increasingly on compensatory strategies, things like devices, the straws, the eating utensils, roller walkers, those kinds of things. So there's more and more challenges to functional activities. Driving safeties, taking a big picture here in this and work capacity, and also changes just across the board in life roles. And then recognizing decision-making capacity may be decreasing, and dysphagia can significantly impact quality of life. All right, late-stage disease. So Mark is now 59, and he's stopped participating in most leisure activities, especially if they require any physical activity on his part. He's experienced several falls, probably multiple falls. This is not uncommon to have someone tell me that they fall 3 times a day. So lots of falls. Falls under walls that actually damage the drywall. Not uncommon. It's something I don't hear in other populations like I do for these individuals. This was his daughter. She has 2 young children. Mark's having trouble accessing his bedroom and bathroom, which are on the 2nd floor, and he's spending most of his time in the recliner on the 1st floor. He's no longer working, and his daughter is now the primary income earner in the family. His mother has passed away, but now he's helping watch over his grandchildren while his daughter's at work. And he's trying to help out around the house as much as he can, but he finds out that he's not able to do much. Getting frustrated about that. So Mark's confused. He exhibits agitated outbursts. He's yelled at his grandchildren during those outbursts. He's had multiple falls so far, all bruises and abrasions and then fractures, but we know that that's likely a matter of time. He's been lucky. He requires assistance to transfer and walk, but he tries to get up and go on his own regardless. He's choking frequently, he's not eating well, and he's lost a lot of weight. He does not talk very much. When he does, they have difficulty understanding him. And his family expresses concern about leaving him alone and in charge of the young grandchildren, but he is often the only caregiver that's available, so they feel that that's the kind of trapped in that situation. What does Mark say? He's not worried about his falling, but says, yeah, I've had a few falls. Not uncommon, again, for that kind of lack of insight and safety awareness. He wants hot dogs, but they won't let him have them. And he thinks they're not very nice to him. He wants to watch his game shows, and he doesn't think they're ready to watch them when he wants to. In the late stage, we start to see kind of a shift into being more really kinetic and rigid, and more dystonia and less chorea. And what some practitioners will say is that the trunk and leg chorea kind of goes away in most individuals in late stage, but maybe we still see it in the head and neck and other extremities. But more radiation, dystonia, and more chorea. There's significant declines in strength, balance, coordination, and losses of range of motion are common. They decreased independence, lots of difficulty with walking through transfers, and as long as they're still able to try to get up and move around, still having lots of falls. Dysarthria with slowness of speech, voice changes, difficulty communicating needs to family and caregivers, and dysphagia, trouble breathing and swallowing. Something else to recognize is that they have trouble initiating their response and have a delayed response time. And so if you ever go in a Huntington's clinic with Huntington specialists, it's kind of odd to watch because you'll see the practitioner ask a question and then this really pause. Some people count I just wait until I'm really uncomfortable and then I wait longer. Because sure enough, that response will come. So typically, you get a response, get an answer, but you have to allow the person time to make that response. So recognizing that, making sure that we're doing it, that other caregivers and healthcare professionals know that we need to do that and allow the person to make a response. And then hopefully we can understand that response. Dementia becomes functionally incapacitating and they're unable to perform work or instrumental anything else. And psychiatric and mood symptoms are harder to recognize and treat at this stage, and it would definitely impairs their ability to socialize with people in public settings. So we want to think about the environment. So Mark is supposed to be sleeping on the second floor, so what's that doing? Are there handrails on the stairs? Is it even feasible, or does it need to be down the first floor? There's a gravel driveway on a slope that's certainly going to be harder to walk on and walk down than if it was a smoother surface without a slope. So clutter throughout the home, and if there's small children around, it probably is. He's tending to drop things and then he can't pick it back up. And so that's problematic. He has a rollator walker. At this stage, there is a period of time where individuals have a lot of trouble with that persistence hanging onto an assisted device. So he has a rollator walker, and there will come a point, which is where Mark is, where he will not be able to keep holding onto it. And he's still able to walk, so he can walk hand in hand, but we kind of seem to go into this period where the only way they can walk is hand in hand. At least that's all I figured out. And then right before they're just not able to walk anymore at all, but recognizing that when you use that ability to hang on to the assistive device. And then we want to identify who are the support people. For him, it's his daughter, but she's having to provide constant supervision, but she can't because she works and she's the sole income earner. So what she's doing is she's feeding him before she goes to work, and then when she gets home from work, she's leaving him in the recliner, and he's in a pair of briefs so that hopefully he doesn't have to go to the bathroom. And she leaves him with a large water bottle that has a straw so that he can have liquids during the day. Not an unheard of or unusual situation, but trying to cope the best she can with the demands that are on her. There's evidence that she may be experiencing fatigue and possibly caregiver burnout, and not to forget that she's also positive for Huntington's. And the only other family members in town are Mark's brother, who's got early stage HD, and his aunt, who's also in late stage HD. And they have their own families in caregiving situations. They're supportive of each other. We want to promote that community of individuals that will help and support each other. We're going to continue baseline assessments, but at this point we'll find that many of the assessments have a floor effect. I know on one of the slides it says that wrong, but you may find that some of those they're not able to do as well anymore. So we may need to add some new ones in at this point in time. What we want to do is maximize quality of life. We're looking more at compensatory strategies and restorative strategies. Lots of caregiver education, physical and cognitive social management strategies for dealing with Mark, but trying to avoid caregiver burnout. And we want to remember to provide that to healthcare workers as well. So is there a personal aide in the home? And we want to provide all of those things to that individual. And if we have people that are in skilled nursing facilities, absolutely in those facilities. And as I mentioned many times, it's a rare disorder. People that are working in those facilities may have very little understanding or training actually in caring for Huntington's disease. Watching for posture and positioning, so thinking about chairs and things that work well for Huntington's disease. There are specific chairs that work better. People with Huntington's in later stages will fall out of bed. We've seen people fall out and hit their head on bedside tables and get significant head injuries, lacerations, those kinds of problems. So watching if those are either cleared out of the way, or that they have soft bed something to help with that situation. Managing falls as much as possible and preventing them. And again, modifying athletic setup, putting a mattress on the floor is another suggestion. Now that just depends again on the size of the individual. So what's that going to do for the caregiver? What can they have a high low bed, or what can you do for that? And physical therapy assessments that tend to carry over a little bit into the later stages better, the T&A mobility test, as long as they're able to walk. The Huntington's disease quality of life caregiver scale is a valuable scale, and the 2-minute walk test may be still do. As you said, likely have a foot that's long on the side would be the 6-minute walk test, the brick balance scale, and the time that we go because of the cognitive issues and other physical challenges. So we're trying to maintain function as best we can, anywhere we can promote independence. Thinking about teaching the family how to do transfers, how to walk with the individual so that it's safe for both of them, preventing contractures, trying to maintain skin integrity, maintaining or improving respiratory status, providing education about positioning and chairs in the bed, helping to keep the person engaged, and managing underlying impairments as best we're able to, like dystonia and bradykinesia. That's an image of a chair called a Broga chair. It's one of the chairs that tends to work well with Huntington's disease. You see the side supports up by the head. They're often fairly well padded on the armrests. And then the footrests we can see don't have all the bars that we can put themselves on. And they can recline and then come back down for easier transfers. There are other chairs as well. So there's some specific chairs out there that work better. Caregiver training, we talked about already. Postural stability training, maybe for sitting now versus standing, especially for staying seated during things like dressing and those kinds of tasks. Multisensory stimulation, maybe hydrotherapy, and maybe video-based exercise. For activities, we're going to really have to modify it. Not things that require a lot of sequences, but kind of a single movement strategy. Also, they have trouble mirroring, so maybe doing it as a cue, but not expecting mirroring to be as successful as it is for some other diseases. Assistive devices, again, may be challenging. And then respiratory function, we want to keep working on the deep breathing and doing what we can to help with that, and watching that positioning is promoting your respiratory function rather than inhibiting it. The biggest focus is on caregiver training. So proper body mechanics, cues for complex movements. That's a list of some of the more common at this point specialized chairs, like the Omega, the Lento, and the Broga chair. Again, falling out of bed is not uncommon, so padded side rails, lower the bed, those kinds of things. And having that discussion, certainly making sure we're aware of what's the appropriate level of care. And where are the people that are going to assist you on the best position. So health, is that something you can afford or access, or just skilled long-term facilities. There are facilities that they're kind of rare and far apart, but there are facilities that focus on Huntington's care that have wings and have more patients that have Huntington's. Those are really nice, and you can access them because the staff are more trained in that area. Try and get that training into whatever facility, wherever there are patients. I mean, we try to go out to facilities that have our patients from our center and offer them education. And then communicating with the team on recommendations. Occupational therapy is going to be focused on assessing quality of life and patient and caregiver interviews, observing behavior and affect, and doing structured assessments like the Elder Depression Scale or PHQ-9. And they're, again, trying to enhance quality of life, healthy routines, and maintaining engagement, and also educating the team. It's probably going to be modified participation. but thinking about how can we modify the things that Mark's been doing, rules, keeping him engaged with the grandchildren, all of those things, home modifications, and safety and injury prevention. So if they haven't already figured out our occupational therapy, certainly looking to figure out what were things that were meaningful to Mark and his family or are now. So maybe use the CFPM, the activity card sort, what are the routines they're doing and how can we possibly modify those. Again, people don't tend to, they're in the throes of it. It's hard to step back and see that simple changes can make your life a lot easier. So trying to get those healthy routines that allow for rest and recovery, facilitating participation, and identifying new goals. See if we have any specific things here. We're having problems now with the individual always being in the chair, always being in the bed, so recognizing there's a little time out of bed and out of the chair, so how can we work with that as best as possible? And if you're going to spend all your time in the chair, then is it a good chair to be in, and what about positioning? There aren't a lot of affordable options if the person's at home, but how can we look at that recliner and make sure that it's the best it can be for Mark? Home modification, definitely modification of the bathroom, or how are they going to do cleaning? How do you get them into the bathroom? So you can roll in shower chairs or multi-use nodes. Maybe we need blankets in bed to help with sleeping, things like that. Do we need chairlift for the stairs if there's not a place for Mark to be on the first floor? And then do we need to think about and can we get approval for custom wheelchair or custom seating that can improve things? And then accessibility. Are they in a home that's accessible? That's another conversation that's often done early when Mark can still make the change, knowing that he's going to have his progression, so his family are going to have needs. So making sure people think about that and maybe make moves when they can. If falls are unavoidable, we're going to think about how can we make it safer. So any type of padding or what's the environment within safe remaining zones for those falls, although we'd like to prevent them all if we can. And then what are strategies for any behaviors that are going on? So de-escalation strategies, kind of communication, the best ways to communicate back and forth, and sensory regulation strategies. And then again, caregiver safety. What are their body mechanics, some alternatives to just lifting the person, and what about caregiver burnout?
I would think that assisting to get up off the floor would be really challenging.
Yeah, I mean, teaching how to get a person up off of the floor, and then it's a safe way, and is there any equipment that can help with that? Especially, again, if the daughter's starting to have balance and posture problems, and she's having to do that every time to be a part of it. Trying to minimize stimulation that leads to agitation, so would headphones help? Are there quiet areas? We talk about grandchildren being in the home. Grandchildren are awesome, but sometimes they're noisy and distracting, or I can't tell you how brain-killing Baby Shark is. So, maybe headphones so he's not hearing Baby Shark go on and on. Darkening the room, strategies like that may help decrease agitation and irritability. Instructing and training partners in the sensory diet, and using multi-sensory interventions for relaxation, reading out loud, listening to music, diffusing relaxing scents like lavender, and deep pressure massage. Touch is so important. What happens the more disabled people get? They get touch when people are working on, but that kind of nice sensory touch and like get massage and tends to cut out of their lives. Speech language pathology assessment in late stage, they have significantly decreased verbal output and difficulty with articulation. And we can see here across the stages of the disease, pronunciation definitely goes down, they're harder to understand, but more variability there. Their average words per second really takes a hit in that mid and late stage. So that's going to have a negative impact on communication. Management in this late stage is a challenge due to their cognitive deficits and severe dysarthria or mutism that are often present. They are unable to use augmented alternative communication, and but they may have some ability to comprehend. You want to remember that as we're addressing and interacting with the individual. Teaching caregivers and ourselves to use that slow rate of speech and really give them a chance to respond. Structuring interactions to be more of a yes/no. So they can give us an answer and allowing plenty of time. And then watching facial expression and gestures. Many times, those are very familiar over time, and you communicate a lot, especially if you're watching for them and if you know the individual. There are appetite changes, much higher aspiration risk, difficulty with medication intake, poor oral health and tissue and feeding dependency, and non-oral feeding support in this stage. And here at AC Stats, they were a little surprising to me. I didn't realize how early on. So dysphagia was present in 35% of early stage Huntington's disease. They may be coughing and clearing the throat effectively, they'll have dysphagia. 94% in moderate and 100% in late stage disease. So definitely need to be aware of that and checking for it before starting early on, like we talked about. Silent aspiration is noted in 28% of those in the late stage of HD. So monitoring weight, hydration, nutrition, and occurrences of aspiration and pneumonia is important. Again, education to the family about that, the risk of aspiration, maintaining oral hygiene, and making sure caregivers understand food placement, appropriate dietary modifications, positioning and postures, management of behavioral and environmental factors, and then management when there is an aspiration or a choking episode. And those are our pearls for this stage. So trying to keep the person actively engaged and active as much as possible. Using equipment to help with mobility, with feeding, eating, all of those things, and a big focus on caregivers supporting them and educating them. So management is a dynamic process that you have to consider individual and personal factors as well as the environment that are going to impact each individual as they progress through the disease. Initially, we're working a lot on promoting self-management and independence, and then we're going to have to switch over a bit to helping caregivers and help us to provide support. And we can be instrumental in educating, maintaining function, and maximizing and improving that for better quality of life. There are a number of resources on that last slide there. There's certainly probably many more, but those are the ones we identified across the different disciplines, and then our references as well. All right, I'm done. Next up in our plans, lunch. Most importantly. So we can take any questions now. If you have any, then We'll bring their lunch, we'll grab lunch, we can take it outside, we can take it, bring it back in here, whichever we want to do. We'll do that until 1 o'clock. At 1 o'clock, we'll come back, and we're going to break into a little bit smaller groups and work our way through a case and go more in depth for each discipline. So we will do physical therapy, speech therapy, and occupational therapy, and talk the nerdy things we like to for each of our disciplines. Are there any questions before we take off for lunch? Sandra, this is Dr. Sandra Costa, and you're what, co-chair? Is that the correct title?
Co-chair of the Executive Membership Study, the membership committee of the HSG.
She's the big boss.
Now, my main role in life is been doing whatever Dr. Kegelmeyer and Dr. Cruz tell me. I run and do this, don't do that. They use me as a control once for a single leg stance study, and I thought I completely recovered from my S1 nerve difficulties, but I haven't. So now I do single leg stance all the time. I'm really pleased to see you all here because people were talking to me, approaching me about how we reach out more to, even speech therapists and different people who've never seen an HP patient before, and how do you do that? And so I'm sitting here, this is supposed to be my lunch break before I just do the family introduction over the 1 o'clock meeting with partners with company, and then really engage. We're trying to get new, neurologists, fellows at different programs who don't have HP programs, and they're trying to seduce them to be HP doctors in the future. So I'm sitting here hungry, okay, because I had to eat early. And I realized one thing that we don't have in this group, and I'm not sure if it fits, is nutrition. We do have, we've had nutritionists work with us in the center, but I have to admit the two words came and went. But speech therapists have a fair amount of interaction with that. But if you don't mind my preaching, which you may notice it's hard to sound something like that. Thinking about hungry, but my husband has a PhD in nutritional biochemistry, works in the World Health Organization for Nutrition and Cancer. And I want to tell you something that he approved that I could say to my patients. Later stage disease patients have trouble maintaining their weight. I recommend ice cream with peanut butter. Do you like cheese? I asked, do you like cheesecake? Eat cheesecake as much as you want. Food restrictions, what that you want to get them to eat. There is OCD, so sometimes in H2 patients, I'll tell them, okay, you go to Wendy's, you order big fries, because French fries are one of the biggest causes of weight gain in America. Chips are also high up there, but our patients choke on chips, so they tend to not eat chips. So I say, go get a large order of French fries. That's okay if you're having trouble maintaining weight. We used to have no obesity in our clinic 20 years ago. We do now. But we do have people who are trying to maintain their weight. If things can be expensive, Kanishiki breakfast is actually cheaper than Ensure. It's pretty good. If you like chocolate, like me, everybody knows you can drive me to that kind of work for chocolate, particularly dark chocolate. That's okay. So just to be a little bit, you're adapting to a population that's different and has different needs, but you would know what are those things that they can eat. To add things, my previous nutritionist told me that peanut butter is a great thing. Putting pumpkin in their ice cream milkshake, which you make for them, but it's ice cream, but it has fiber and other things. So I'm suggesting you be creative, but I'm sure that in terms of the other things that this group knows in terms of speech therapy, physical therapy, and whatever, I just listen to my experts in the field. But it did dawn on me seeing here as you did the summary that we might want to incorporate some input also from nutrition specialists. There aren't that many HP groups to this kind of group where we're working on approaching the difficulties of families. I'm actually glad I walked into the interruption.
I just gave us some permission to go down the hall and get the ice cream.
I confessed the other day, I eat, people tease me about what I eat lots of beans, I eat this, I have vegetables. My husband's getting tired of the way I cook, because I think when the other day I didn't have time, and I walked by a restaurant, had for lunch, I had a banana and cat coffee, coffee, almond, mocha ice cream. So I don't usually follow those recommendations for the high foods for lunch, but I do recommend that for my patients. I will even let them eat bacon eggs if they want, just not every day. All right. So
lunch is, I don't know how many people, but down the hall towards all the signs in the main meeting, it'll be sitting out front where you'll have your family day, which Ash showed for sure can start to use on way again. We should probably sit outside and enjoy some fresh air. And no more.